So now we are done with stomach. Next, we'll move on to the intestine, starting with ulcerative lesions of the intestine. So this ulcerative lesions of the intestine was a very favorite topic during MBBS time also. So let's see the differential ulcers. Okay. So tubercular ulcer, typhoid ulcer and amoebiasis. These three are the major ulcerative diseases of the intestine. So in the tubercular ulcers, all of these three lesions, three ulcers are going to be located in the ileocecal region. So cecum is definitely involved. So ileocecal junction, here more of the cecum. And in amoebiasis, we can also have liver involvement. You get liver abscess, right? History of liver abscess will be given. But the appearance on gross morphology itself is going to be different for these tumor. Suppose it was a tubercular ulcer, you are going to have a transverse ulcer. Suppose this was the intestine, you are going to have ulcers like this. So transverse ulcers will be there. In typhoid, if you see, it is going to be longitudinal ulcer. The ulcers are going to be like this. Then in amoebiasis, the ulcers are going to be flask shaped like this. So rather than being deep, they are going to be wide. So starting from the epithelium, it's going into the submucosa quite wide rather than going deep into the muscularis propria and serosa. So flask shape ulcer is present. So this was the most important thing you need to remember about this. And how do you remember it? I usually use this thing. So typhoid is tie, you think tie. So necktie is going to be quite long. So this is how I remember. Tie is long. Okay. So this is how I remember. You can remember it however you want. So usually the tubercular ulcer will complicate with a stricture. So chronic tuberculosis, it is going to form a stricture. So later on, it can perforate, but most commonly it will present with a stricture. While typhoid ulcer, the findings you see is neutropenia. So generally also in the blood counts, there will be, even though it is a bacterial infection, still you are going to have a neutropenia. So it is one of the exceptions. So typhoid fever, you always have neutropenia with relative lymphocytosis. And there is a special type of feature called as Zenker's degeneration. So this Zenker's degeneration is seen in typhoid fever, and it is actually a coagulative necrosis only, type of coagulative necrosis occurring specifically in skeletal muscles. So skeletal muscles like that of the diaphragm and abdominal muscles. So abdominal muscles and diaphragm, you have this coagulative necrosis called as Zenker's degeneration, seen mainly in typhoid fever. So in typhoid, the kind of fever they develop will be a stepladder kind of fever. So the fever will have this kind of a pattern. And we all know the most common organism causing typhoid fever will be Salmonella typhi. But the Salmonella typhimurium, so Salmonella typhimurium is going to cause osteomyelitis in sickle cell anemia patients. So most common cause of osteomyelitis in sickle cell anemia patients will be a Salmonella typhimurium. So coming to amoebiasis, I already mentioned they will give a history of liver abscess. So if you drain that abscess, it will give a characteristic appearance which is called as anchovy sauce pus. So anchovy sauce pus will appear like this, some pinkish brown material. So this is the appearance of anchovy sauce pus. And on microscopically, you have a special feature called as erythrophagocytosis. Basically, these trophozoites are quite invasive and they'll invade this epithelial cells and then they will cause lots of hemorrhage and they'll eat up the RBCs. So in this image, if you see, these are the amoebic trophozoites. All of these are amoebic trophozoites. So here if you see, there is a pink colored dot here. So this is the kinetoplast. So these are the kinetoplast of the trophozoites. And in this image, again, if you see, there is this trophozoite is eating this RBC here. In this hyper also, if you see, here again it is eating RBCs. This also, multiple RBCs are being eaten up. So this kind of feature is called as a erythrophagocytosis by the amoebic trophozoites. So erythrophagocytosis by the amoebic trophozoites is seen. So one other thing is a pseudomembranous colitis. So pseudomembranous colitis is a infection caused by Clostridium difficile. So Clostridium difficile infection will be seen in patients who are taking long-term antibiotics. Suppose they are taking third generation cephalosporins. So some kind of, whenever they get diarrhea, some people tend to take lots of medicine, so antibiotics. So when they are taking lots of these antibiotics continuously for a longer time, they can develop this Clostridium difficile infection, which can lead to the formation of pseudomembranes. So pseudomembranes on gross, it will appear like this yellow colored, these yellow colored patches. So these yellow colored patches are nothing but the pseudomembranes, which are composed of the necrosis and the exudate. So exudative and necrotic lesion is called as the pseudomembrane, which is seen on the mucosal aspect usually. So microscopically, if you see, this pseudomembrane is going to appear like a volcano or a mushroom. You can call it like that. So this is the normal intestine. From here, if you see, this is the area of ulceration, and above which it has formed this pseudomembrane. So lots of necrosis is there, inflammatory cells are there, and also this kind of granulation tissue is also being formed. So this pseudomembrane, if they give this image, it is a spot diagnosis you should make. It is a pseudomembranous colitis caused by Clostridium difficile infection.